Before we start, one second. Okay. Yes. So, before we start, I'd like to, introduce Yusuf. So, very good evening, everyone. Thank you for being here in this meeting and, giving your valuable time. We have Dr. N. Arun with us, who has over 10 years of experience in the space of gastroenterology and is currently practicing at Apollo Hospitals, Chennai. So, it's a pleasure to have you. Thank you for your time and looking forward for your valuable and insightful session on practical approaches towards diagnosis and management of IBD. So handing over the session to you, sir.
So, good evening, dear friends, respected professors, senior consultants, and it's really a great pleasure for me to meet you all once again in this wonderful forum to discuss something about inflammatory bowel disease. And I would like to thank Team Reddy's who gave me a wonderful opportunity to share in this wonderful evening regarding the one of the most complex scenario, most complex event in which most of the gastroenterologists, even for the best of gastroenterology, will be having difficult to manage such tough scenarios right from beginning. What are the medications you need to initiate, followed by what are the various molecules you need to try, how far you're going to monitor, how are you going to screen, how are you going to diagnose. There are so much of diagnostic dilemmas are still happening when you're going to manage a patient with inflammatory bowel disease, because as we all know, inflammatory bowel disease is one of the complex entity in which it contains two major diseases, nothing but your Crohn's as well as your UC, ulcerative colitis. In this, there are age preponderance will be from pediatric to adult and as well as various age group of presentation, right from 10 to 60 years, your varied group of presentation will be there. And how are you going to diagnose? What is the basic reason for any patient who is going to develop? Once a patient is going to land up with any complication, how are you going to approach? How are you going to manage? That's the most common area for me to discuss with you all right now for a few minutes, right from the basics to the advances in management. What do you mean by inflammatory bowel disease? It's a group of idiopathic chronic inflammatory intestinal condition in which you couldn't able to identify the etiological source. It could be because of genetic manipulation, or it could be because of idiopathic nature, or it could be because of gut dysbiosis. The one major concept right now which is progressing is gut dysbiosis. We don't know what is the reason for this IBD to get progress. It's a multifactorial problem, and at least in a week in our practice we'll be seeing at least 3 to 4 cases of inflammatory bowel disease, in which if you're going to manage, the most complex scenario will be usually we'll be encountering ulcerative colitis, but Crohn's disease also should not be forgotten. But once the patient is going to get land up with evidence of Crohn's, the treatment duration will be prolonged, and moreover the cicatrizing, the scarring lesions, all those things will be more common in Crohn's rather than IOC. The prognosis is always guarded when you're going to manage a patient with Crohn's. How are you going to establish a diagnosis? What are the various closely associated differential diagnoses? All those things is very, very important. When you're going to label the patient as indeterminate colitis, in which if we couldn't able to come to the conclusion whether it is because of Crohn's or whether it is because of UC, there are so many interesting pointers. Even one day will not be enough. So frequently we'll be having major discussion. So much of research has been happening, and not even one single molecule as of now been significantly proven to have a beneficial role. There are multiple molecules being tried, but steroids still be having a potential role when compared to other line of drugs. But among them, once a patient is going to steroid resistant or steroid refractory, at that point of time, when you're going to switch her to other second line of molecules, you'll be having so much of diagnostic, you will be having so much of confusion, how to progress, how to titrate, how to step up, how to de-escalate your regimen. There are so much of questions still need to get addressed well when you're going to manage a patient with IBD. As we all know, more than 6.8 million population globally been identified with this IBD. Among them, you see, if you're going to see, it is predominantly limited to your large bowel. But in your case, if you're going to look into your Crohn's, right from your oral cavity, right from your mouth to anal canal, anywhere, it can involve your esophagus, it can involve your stomach, it can involve your small bowel, it can involve your large bowel, very common, and it can predispose only to ileitis or ileocolitis. Various presentation may happen with your Crohn's disease. So how are you going to diagnose? Most common scenario, you need to have a comprehensive clinical examination. Without proper clinical examination, it will be very difficult for us to diagnose any patients. So we need to spend time with the patient, proper clinical examination, proper physical examination, and review the patient's history. Most of the time, the patient will be having multiple medication. The patient may be constipating, the patient may have diarrhea, the patient may have bloody even. Most of the time, the patient will be reviewed by multiple doctors, followed by doctors shopping for long duration, and then the patient may come back to us. So we need to review the patient history, how the events, how the semiology of this disorder has been progressed. That has to be analyzed promptly if you want to manage a patient with IBD. And basic blood investigations, your stool routines, as well as your endoscopic examination. In case if needed, we need to go for biopsy. What are the patients? How are you going to subject the patient for various imaging modalities? These are all the basic outline which will help you to confirm your diagnosis. As we all know, the common presentation will be, see, if it could be because of multiple events, the common either by your bloody events or by a diarrheal source. It could be mucus diarrhea or it could be a bloody diarrhea. The common presentation, around 50 to 70% of the population will exhibit diarrhea. Among them, abdominal pain is one of the characteristic event that will be more characteristically identified when you're going to diagnose with Crohn's. Around 70 to 80% of the population will be having evidence of abdominal pain. It might be periumbilical or it might be in your colonic region. So based upon your clinical presentation, and Crohn's disease sometimes will be having evidence of vomiting, and more of weight loss and other symptoms will be most significant when we are diagnosing with evidence of Crohn's, and multiple extra GI manifestations. You should remember, I'll be taking over in my upcoming slides. There are so much of extra GI manifestation. Among them, any fistulizing lesion, any abscess formation. There is high possibility we are not supposed to forget your Crohn's pathology. So the presenting symptom, if the patient is having persistent diarrhea, if the patient is having alarming events like weight loss, if the patient is going to present with evidence of bloody diarrhea. So why I'm taking over this presentation, not to brush up the basics for all the physicians who are being attending. We should not forget the basics. In order to do that, once we able to identify the basic knowledge about this IBD, we can able to take on with the advanced area of discussion. So the basic brushing today is the most important concept for me to take on the discussion for the next 30 to 40 minutes. So the presentation, we need to be very cautious, and we need to analyze how the events, how many episodes of diarrhea, for example, if the patient is having bloody or mucus, whether the patient is anemic, followed by whether the patient is developing manifestations of anemia, how severe is the anemia, coexisting presentation, your SIRS criteria, for example, if the patient is going for evidence of septicemia, or if the patient is having tachycardia or bradycardia, whatever the presentation. So based upon your heart rate, based upon your respiratory rate, your SIRS presentation to be analyzed based upon the evidence of dehydration. And these are all the presentation we should not forget. Once the patient is going for evidence of anemia, assessing the severity of anemia is very important. Severity, based upon the severity, which is to be given prioritization. So treat the anemia first. Look for evidence of coexisting B12, folic acid, iron deficiency. Even then, if the patient is going to land up with evidence of iron deficiency, there is high possibility for these kind of patients to be in septic focal. So be very cautious when you're going to subject the patient with iron. So these are all the areas we are not supposed to forget. The bloody diarrhea, your abdominal pain, significant weight loss with coexisting complications. These are all the common presentation before you're going to subject the patient for further investigation. And we are not supposed to forget this diarrhea, this bloody mucus diarrhea. There is high possibility for us to go for tenesmus. That means your rectal symptoms is being more common. You will be having, when you're planning to defecate, the pain symptoms will be more common. Chinese mouse is well pronounced. As we all know, the rectum will be most commonly involved in UC. Most of the time when you're going to look for Crohn's, there will be having sparing of the mucus, so there will be having skip lesions will be more common in Crohn's disease rather than in your ulcerative pathology. So always you should be very cautious. Look for any evidence of recent travel, take the history properly, any past history of infections. For example, if the patient is going to have evidence of abdominal tuberculosis that mimics, if ileocolonic tuberculosis, there is high possibility that will mimic your Crohn. So always you need to treat. So there are multiple protocols. Some patients may be treated fast with tuberculosis drugs of management, followed by some patient may be subjected to evidence of Crohn's another day. So how are you going to assess the based upon the clinical picture, your diagnosis, your biopsy, your status, what are the molecules you are going to try? All these pointers is very important. Your travel history, your medications, if the patient is going for any evidence of antibiotic associated colitis, for example, a Clostridium deficit pathology, if anything is going to get happen. Next to that, if the patient is going to subject with any drug abuse like NSAIDs, or in the background of any family history, any smokers. So smokers, as we all know, one will be protective, one will be worsening the event. So smoking is one of the predisposing factors we are not supposed to forget, but you see to some extent it will protect you see, but these are all the myths and concepts we're not supposed to forget. But basically, we need to look for the triggering pathology. We need to identify the clinical presentation. We need to see how far the event's been progressed. What is the nutritional status? What is his BMI? What is his weight? What was his present weight? What was the past weight? How the events has been progressed? In what way? How is the severity of event? What is the how much of episodes of stool? How much of blood been lost? All these pointers is being very important to categorize. Based upon that, there are various categorization. For example, you've been Crohn's disease activity index is UC ulcerative colitis disease activity index is and followed by your True-Love criteria is there for your UC. There's so much of diagnostic criteria is there to diagnose your ulcerative colitis IBD. Crohn's, but the clinical examination, the clinical presentation, the clinical approach matters a lot when you're going to manage an event like this. And always, we are not supposed to forget, as the age progresses, there is high possibility for this kind of patients to turn to be a malignant changeover. So the diarrheal event, and sometimes can be a predominant constipation that might be missed out, and some patient will be an obstipation with no passage of flatus absorbed in bowel. In case if the patient is going to present with evidence of obstructive cases, some patient with Crohn's, there is high possibility of rectal bleeding, mostly in favor of UC, and bowel movements, Chinese presence were all in favor of UC. Your crampy pain, if it is going to be in periumbilical region, there is a possibility for you to locate your Crohn's, but if it tends to be in the left lower quadrant, that might be a predominant UC pathology. So nausea, vomiting, and that was we discussed. Once a patient is going to get evidence of small bowel involvement, there is a possibility of Crohn's to take on. So at that point of time, so you need to do a detailed upper GI as well as lower GI study. Sometimes if the patient is having persistent symptoms, the blood loss will be there, occult blood loss might be there. We couldn't be able to identify what is the nature. It could be because of your Crohn's, which might happen in your predominantly only in a small bowel. So detailed workup before you're going to subject the patient with enteroscopic analysis. So why I would like to point out the clinical history taking, your clinical assessment, your basic blood workup, your basic ESR, your basic CRP, your basic markers, your basic acute inflammatory reactions, all those reactants, all those things is supposed to be subject when you're going to manage a patient with IBD. So how are you going to differentiate based upon your clinical presentation, either it's because of UC or because of Crohn's? In Crohn's, always the bleeding will not be more common, will be slightly less when compared to, because usually even then if it is diffuse involvement, and the structurizing lesions will be more common in your Crohn's rather than in case of UC, and fistulizing lesion will be more common in Crohn's rather than in UC. And toxic megacolon, if the transverse colon diameter, if it is going to be more than 6, there is high possibility for you to diagnose your toxic megacolon, which will be more prepondering because of your UC. But you should not forget other characteristic differential diagnosis like health-related abnormalities, so many other things which may mimic your toxic megacolon. These are all the differentials we're not supposed to forget. And even then, once if you're going to get diagnosed with this kind of presentation, we need to look for serial progression, how the patient is going to respond, and whether there is any evidence of malignant changeover is there or not. Because as we all know, in case there are so many coexisting complications. For example, I have seen some patients who presented to us in the background of UC along with evidence of jaundice. That might be a coexisting primary sclerosing cholangitis. We are not very sure whether it's because of that, or some patient may be having evidence of small bowel adenocia because of your Crohn's. So as the day progresses, the risk of colonic cancer will be high. So we need to characteristically monitor, titrate, assess, and diagnose and treat. That's the most important thing when you're going to manage. Apart from that, we all well remember about the GI, but right from a basic knowledge, right from a basic MBBS to a master degree, we'll be having the basic extra-intestinal complications that we will never supposed to forget. Arthritis is one characteristic complication, can happen in your UC as well as your Crohn's, but it could be oligo or it could be poly. But once a patient is going to have evidence of arthritis, how are you going to subject, whether you're going to use NSAIDs, when you're going to use NSAIDs, how are you going to have, whether the patient will be having complications, so much of questions, so much of doubts is there when you're going to manage, and steroids role. And once a patient is going to subject with steroids, how the arthritis is going to respond, or if the arthritis, if the patient is not going to respond, that patient, some patients will have evidence of erythema nodosum. That's one characteristic presentation. We have tendinous swelling. So once a patient, that will be painful. I have seen recently a young boy who just completed 14 years of age who presented to me with prominent erythema nodosum with severe tenderness along with evidence of active Crohn's. So, but we are not very sure. So when you're going to subject the patient with steroid, whether it is going to respond or not, but it responds voluntarily. The symptom and events has been subsided on its own in it as the day progresses without any major line of medication except for steroids that have been given to the child. So why I would like to explain this scenario, we should not forget other extra GA manifestations like your ankylosing spondylitis, your pyoderma, your erythema nodosum, a common your often manifestations like your uveitis, your iritis, your scleritis, your main hepatic focus of PSC, all these things. And once a patient is going for other GM manifestations, like your avascular necrosis, ortho complications like osteoporotic changes, your vitamin D and calcium deficiency for long-term usage of steroids, and you may see always this disorder, you need to counsel the parent, you need to counsel the patient, you need to, so the long-term medication, the costly one, all those things, affordability, all those things, the compliance of the patient, all those things is supposed to be, and most of the patient will be having mood disorder. They may go for depression because long-term follow-up, long-term medication. As we all think that even for one day we couldn't able to spend our time out of focus, but this kind of patients need to be completely focused towards the health and other issues. So they will be having mood swings and other things. We are not supposed to forget, and we need to address that. Another common disorder like non-alcoholic fatty liver because of your steroids, another molecule when you're going to use, because of other molecules when you're going to try, or because of the coexisting presentation. You may have gallstones, you may have nephrolithiasis, and multiple other extra GA manifestations may be there. So why I would like to show this picture, the physical examination, we should not forget you may have aphthous lesions, you may have arthropathic changes, you may have uveitis or scleritis. This is what we discussed is erythema nodosum. Recently, we have encountered with multiple patients that have seen that pyoderma gangrenous, even though it's slightly rare, you may be having such patients. It can happen even in your even in your buttocks and other area, and you should not forget your sweets, which is nothing but your neutrophilic dermatosis and your skin tags, your perianal tags, and your fissures might be. So always you're not supposed to forget the complex fissure is one of the most characteristic presentation of your Crohn's. That good salts, always you should not forget about your fistulizing lesion. The fistula will be a complex fistula, and that's very common scenario to treat when the patient is going to have a fistulizing lesion. At that point of juncture, there is high possibility you need to subject the patient with monoclonal antibody. For example, infliximab definitely is going to take on with a significant role when you're going to initiate the patient 5 mg per kg. But why I would like to point out, there are so many extra GM manifestations. So detailed clinical assessment for your IBD, detailed clinical semiology of events presentation, now the clinical progression and physical examination. So look for the well-being, your panel, your nutrition, your pulse rate, your BP, basics, and look for the perianal region. Never mess out any finding. Do a proper perirectal examination to diagnose the problem. And once a patient is going for abdominal examination, look for evidence of mass or distension. It could be because of coexisting malignancy, or could be because of small bowel CA. We don't know what are the coexisting problems. So look for always evidence of mass, or it could be because of fecal lump, which is going to get abstract. So evidence of all those things, your tenderness, your altered bowel sounds, evidence of obstruction, any evidence of jaundice, hepatomegaly, look for any evidence of surgical scars. As I discussed, the extra GM manifestations, we are not supposed to forget the entire picture. When metabolic bone disease is very common scenario, once a patient is going to switch on to long-term steroid support, some patient may be having steroidal dependent. So all these pointers is very, very important when you're going to use your steroids for inflammatory bowel disease. Start look into your basic lab parameters. How are you going to represent? So basics will be, in case if any acute onset of diarrhea, once a patient already been diagnosed, the patient will be in remission. But at that point, any new onset of worsening of presentation, that might be because of bacterial or viral or parasitic focus. Any acute onset of diarrhea, you should not forget your Clostridium difficile, your antibiotic colitis. So look for evidence of occult blood or fecal leukocytes. This is all not much of sensitivity, but you can do a basic investigation if you want to look for any. But always you should not forget, once a patient on chronic steroids for longer duration, once a patient is going for immunosuppressive, there is a possibility for the patient to go for evidence of cytomegalo, Clostridium difficile colitis. All those things can progress, and you need to look for your fecal markers, that the acute phase reactants. You should not forget your calprotectin, which is being the derivative of neutrophil, and your lactoferrin, as well as your alpha-1 antitrypsin. These are all the basic markers we're not supposed to forget. And fecal calprotectin can be as sensitive as if it is going to be more than 100, or if it is going to be more than 200. There are so much of cutoffs there, but fecal calprotectin can be taken as an indicator, but that's not the only indicator to diagnose your IBD or Crohn's or UC. So once the basic blood count, your basic blood count, you need to look for evidence of leukocytosis, anemia, and what I discussed, some patients may exhibit thrombocytosis because of your inflammatory activity, and you need to look for evidence of your ferritin status. It might be elevated, and transferrin saturation, and next to that, your electrolyte, because recently I have encountered a boy who presented to us with the albumin of 1.4, the severe protein loss. So at that point of juncture, how are you going to manage whether this kind of patient needs albumin support? If you're going to give albumin support, you're going to give 5% or 20% based upon your liver parameters. See, these are all so many questions need to get addressed when you're going to manage a patient with inflammatory bowel disease. And your calcium, your magnesium status, your B12, because once a patient is going to get involved in the involvement of your terminal ileum, so B12 process definitely is going to come down. The absorption of folic acid and B12 definitely is going to get impact. So all those things you need to assess. And any patient who's having evidence of chronic diarrhea, a celiac disease is not supposed to forget, because late onset, adult onset of celiac, as we all know, the tissue transglutaminase, that's the basic one, and gliadin status is to be assessed. If you want to diagnose, you may need to go for a diurnal biopsy, D3, and also all these things to be looked into that, and followed by you may need to subject with the gluten-free diet and other things. And celiac antibody testing is one common scenario we saw. We are all not supposed to forget. And the pro-inflammatory marker, the ESM might be more than 100, the CRP might be significantly elevated, and you need to look for your ANCA as well as your ASCA. So ASCA positivity might be having evidence of Crohn's, and ANCA positivity might be having evidence of UC. And always we should not forget of your infective pathology, the common scenario HIV, because of your immunosuppressive status and your hepatitis B, C. Once your patient is going to subject with monoclonal antibody, there is high possibility for this kind of infection to get progress at that point of juncture. It will be very tough scenario. Multiple scenarios I've encountered. I have diagnosed a patient with IBD, treated for IBD. Within a span of time, the patient, the young girl who just turned to 1 year old, rapidly gets fulminant septicemia. We don't know what is the reason. When we did the imaging, we showed evidence of miliary tuberculosis pattern. and within a span of time, that patient collapsed, and that patient, even though it has been progressed to total colectomy, we couldn't able to revive the girl. So this kind of presentation will be more common. So you need to assess, you need to counsel, you need to titrate, you need to monitor when you're going to manage a patient with inflammatory bowel disease. Very complex scenario, looks to be simple, but treating will be very complex. So you need to be very cautious. We need to be very, serial monitoring, titration, everything is very important when you're going to tackle a patient with IBD. So imaging definitely will be having significant you can able to identify, but not much of significant beneficial role. But examine once the patient is going for evidence of colitis or obstruction or perforation or toxic megacolon, definitely you can go for X-ray and sigmoidoscopy and colonoscopy. Definitely we need to go along with the upper GI endoscopy if you're going to suspect your Crohn's and other problems. Some patient may be having evidence of small bowel pathology. At that point of time, we need to go for endoscopy or enterography or MR enterography, and DEXA only to assess your bone scan. Once a patient is going to subject to steroid, barium not much of role, but in case if you're going to identify any fistulizing lesion, you can use a roadmap. But X-ray radiography, your HRCT and other imaging is very important before you're going to conclude. You're going to rule out that there is no evidence of tuberculosis, and you may subject the patient with IGRA, or you may subject the patient with TB quantiferol, or you may subject the patient with gene expert, or whatever the investigation you are going to plan. We are not very sure whether they've been significantly ruled out tuberculosis, because once you are going to start on monoclonal antibodies, that will be always having a doubt whether this kind of patients will progress. And I even recently have treated a boy who presented to us with this kind of extensive ulcerative colitis, in which I subjected him to adalimumab. Even then, for him right now, it turns to be a IGRA positive. But IGRA positive doesn't mean he's having evidence of active events. But clinically is fine, and X-ray imaging, everything is fine. We are not very sure whether it is because of latent event or whether it is because of active tuberculosis, whether to continue the molecule or not. So much of diagnosis dilemma still progressing in my mind. I don't know what, so to approach, how to progress. These are all the various things. Once you start treating a patient with this kind of scenario, will be frequently encountering. So you should not forget about the basics. And now new investigations, chroma endoscopy to identify any dysplastic focus, early identification of dysplastic lesion. See, this is how the endoscopic pattern will be there. So you can able to identify your erythematous mucosa, your loss of vascular pattern, your friable mucosa, high granularity. With all those things will be more common extensively involved. It could be a left-sided, or it could be extensive, or it could be pancolitis, or it could, so all this presentation can be there. Once the patient is going for colonic Crohn's, and you can able to see a deep fissuring lesion with cobblestone mucosa. These are all the pointers we should not forget when you're going to manage a patient with IBD. So capsule endoscopy, if you want to identify a patient with small bowel pathology, we can use that. MRCP for your PSC, your cholestatic pathology, any patient who is having jaundice, your pruritus, vitamin A, D, E, K deficiency in the background of UC. The patient is progressing. So always you need to look for PSC, which is being happening or not. So usually around many patients will be reported with that PSC as a coexisting complication. So PSC and UC will go together most of the time. We should not forget that. So we need to work up if the patient remains stable or not. Once the patient turns jaundice, that's the most important differential diagnosis as to strike in your mind. And enteroscopy, now spiral enteroscopy, motorized, is very common. Recently in AAG, we have seen a patient who presented to us in the background of obscure GA bleed, a suspected Crohn's, in which in the video demonstration, we can able to identify a prominent lesion in the jejunal mucosa, a prominent ulcerated mucosa. Upper GA is fine, lower GA is fine. Only in the jejunal mucosa, we can able to identify the source of obscure bleed. So why I would like to point out 8 to 4 area, anywhere, there is high possibility for you to land up with evidence of Crohn's disease. Your imaging, your CT, your ultrasound, MRI, all this can aid in diagnosing your pathology. But the most important thing, we should not forget the differential diagnosis of your UC as well as your Crohn's. Once you're going to look into your clinical picture, once you're going to diagnose that, We need to see whether the patient is going for evidence of TB, or whether the patient is going for evidence of ulcerative colitis, or whether the patient is progressing for Crohn's. Various differential diagnosis it should be. Always your Behçet's will mimic your UC. It will be oral involvement. The patient may be having evidence of active bleed, GA bleed, Behçet's. You should not forget radiation colitis will mimic ischemic colitis. Even then it's severely painful condition. That might be one possibility. Tuberculosis always the closest to differential diagnosis, even though predominantly iliac mucosa because of your patch involvement. But tuberculosis, you need to treat, you need to count. Even then, if the patient is not going to show evidence of gene expert negativity, negativity, doesn't mean the tuberculosis is not there. There is possibility, and still we need to be serially monitor for sequential colonoscopy, imaging, other assessment to be done, whether the patient has been excluded with just tuberculosis or not. And amoebiasis, a coexisting add-on trigger, and your other events like your diverticulitis as well as your NSAIDs abuse. All this possibility can be there when you're going to manage a patient with your IBD. It could be a differential diagnosis of your presentation that we are not supposed to forget. It could be of intestinal lymphoma, small bowel lymphoma. We don't know, but that's how we need to approach a patient when you're going to manage a case with IBD. So definitely diagnosis, you need to look into the clinical presentation, your serological events, and your biopsy, histopathology. In IE area of TB prevalence, even then a TB culture, if it is negative, you need to go for the biopsy specimen to look for evidence of tuberculosis, is there or not, even then if you're going to suspect a patient with IBD. So features, what are the common differentiating points? As I told you, yet to food will be more common, will be in Crohn's, but it will be less common in UC. Once predominantly bloody mucus diarrhea will be in UC and less will be in Crohn's. The patient extra GA manifestations will be more common in Crohn's rather than UC, but endoscopic involvement will be of a diffuse inflammation. But in this case, you'll be having only transmural involvement. So non-caseating granulomas will be the characteristic presentation of Crohn's, and your cobblestoning, your longitudinal ulcers, all these areas can be able to identify. Your skip lesions will be more common in Crohn's, and fissures, deep fissures, your granulomatous inflammation, and your ANCA and ASCA, always fistulizing, abscess, extra GI, high possibility of Crohn's, weight loss, significant malnutrition, significant nutrition deprivation, high fever, all these pointers slightly more in favor of Crohn's, but acute bleeding, tenesmus, severe abdominal pain in the left lower quadrant, all these pointers will be more common in favor of UC based upon your clinical presentation. As I discussed, we need to work up the patient based upon the differential diagnosis. Your list is there. Also, we should not forget our basics like your vascular pathology, like your HSP, your collagenous colitis, your Behçet's, and sometimes even the colitis if it is going to get complicated by your HIV. All these we are not supposed to forget when you are going to diagnose a patient with UC or CD. So how are you going to approach? Once you are going to make an initial clinical evaluation, so this is what the Vienna classification of your Crohn's, based upon your age, based upon your location, based upon your behavior. If you are going to be less than 40 or more than 40, where the disease even is going to be in ileum or colon or ileocolonic or upper GI, or whether the behavior is stricturizing or penetrating, or only stricturizing or only penetrating. So what is that? The non-stricturizing or non-penetrating, or stricturizing or penetrating. So based upon that, your Vienna classification need to go for true low weights for a severity, UCAA index, and your Crohn's disease index. You need to follow all these guidelines when you're going to manage a patient with your IBD. So go for your biopsy, colonoscopy, endoscopy. Some patient may subject for upper GI also, and look for evidence of non-caseating granuloma. If it is there, it might be Crohn's, and identify the severity based upon your Vienna. And if it is, suppose if it is not there, any endoscopic evaluation of your ulceration, fistulization, or your cobblestoning mucosa shows evidence of Crohn's. If it is not there, look for evidence of fistula, abscess, or large skin tags. That might again shows evidence of Crohn's. Even if it is not there, look for evidence of terminal ileum involvement. That's high possibility, terminal ileum involvement, rectal sparring, focal lesions, growth retardation will be more common in case of Crohn's. And if you couldn't able to diagnose all these things, then you may label the patient as indeterminate colitis. But once if you can't able to identify this, there is evidence of rapid blood loss, tenesmus, characteristic presentation, and extensive mucosal involvement in your colon, sparing of the other region. So there is high possibility for you to diagnose with ulcerative colitis. Now, the most common area that I would like to address in a brief way, the management process is very complex. First, you need to counsel the patient, analyze the event, look for the severity of the disease, how the event has been progressing, and what is the basic drug, whether you're going to start first with steroid or whether the patient be presented with acute severe colitis in which the patient deserves intravenous steroids like your hydrocortisone, methylprednisolone. So what is the line of treatment you're going to subject based upon the clinical presentation? You need to analyze based upon your markers, your fecal calprotectin, your histological parameters. Main thing, never forget your clinical presentation, your SARS and other events, your CRP, ESR, fever, toxemia, which depends upon that, followed by you are going to diagnose the acute severe colitis. At that point of juncture, most of the patient may deserve intravenous steroids for a duration of time, followed by you can switch on to oral steroids, and you need to maintain, look for evidence of steroid dependent, steroid responding, or steroid resistant, whether it is happening or not, whether the patient deserves second line of medications or not. So disease location, your phenotype, your severity, your complications, you need to assess your tolerance and all these pointers, and you need to consider diet. So what is the diet pattern? You need to calculate your fiber, decrease the amount of fiber because that may help you to alleviate your diarrhea, to reduce your diarrhea. And dairy products usually may not be well tolerated. A low residue diet and high residue diet, sometimes we may recommend in ulcerative proctitis and cessation of smoking and reduction of your stress. These are basic things we should not forget. And the first line of management, any common scenario, to start with your 5-amino salicylic acid support, for example, your mesalazine. The common molecules what you're going to use in multiple centers start with 2 to 4, 2.4 to 4.8 milligrams, grams per day of your disease based upon your disease severity. And whether you're going for 2 grams sachet, whether you're going for oral or rectal preparation or any matters preparation, there are so many topical brief molecules are there. That's not the area for me to brush. When you're going to use, there are so much of adverse events will be there, so much of response will be there, but this alone will not be adequate to maintain a good remission for your IBD as well. But once the patient attended remission and once the patient is preventing relapse, to maintain that, we can use amino salicylic for a duration of time, but isolated molecule recommendation in case of active UC, there is no much of beneficial role when you're going to titrate. So either you're going to use oral or rectal preparation of 5-SA, or you need to go for combination or rectal support. And based upon that, these are the various studies what they may mention. Once if you're going to use your 5-ASA preparation, response rate will be slightly better in case of UC. That's what the trial has been proven. And this, if you're going to use in controlling your active inflammation and when you're going to use for maintaining your remission, there is high possibility. So maintain a dose of around 2.4 to 4.8 grams per day when you're going to use mesalazine, and look for the adverse events like your diarrhea and other problems when you're going to use bacillazine or valsalazine. So all this point is to be addressed when you're going to use a molecule of mesalazine as a first line of support, as a primary management in case of IBD to maintain a remission and to prevent relapse. So these are all the various RCTs in which the various dosage regimens for a duration of 12 months to 6 months, in which the relapse rate has been significantly lower when you're going to use this mesalazine when compared to your placebo. So this is what, again, the same trial which based upon the multiple molecules. One is because of ileal release, one because of controlled release. There are various release preparations. That's a separate area to discuss, huge area of discussion is there. But briefly, we should not forget, based upon that, your pH dependent nature, your colonic pH maintenance, your ileal release pattern, all those things, more proximal release of drugs will be more beneficial when you're going to use your mesalazine. That's the most important thing you're not supposed to forget. And the next most important thing, your steroids, the primary line of molecule will be your prednisolone. Start by 40 or up to 60, mainly by 40 milligrams, and slowly titrate the dose and maintain the drug regimen up to 5 milligrams per day over the period of time. Look for a response, whether it is there or not, and followed by you can able to titrate. acute severe colitis, either you can go for hydrocod or methylprednisolone, but rectal supports or preparation, your budesonide and so many other new molecules been there. But what's the concept? Even your MMX coated technology for your budesonide is being well available for your moderate to severe colitis. But my personal recommendation, when you're going to use your patient with steroids, always the best of potential molecule to consider your prednisolone rather than going for your, if the patient is going to have mild to moderate colitis, okay, going for budesonide is well okay, accepted, but severe colitis, budesonide strictly, we need to know more validation if you are going to consider. The primary molecule will be prednisolone, will be more better tolerating when compared to your budesonide when you're going to manage a patient with inflammatory bowel disease. So this is how we are going to titrate with your steroids. Various titrating regimens are there, slowly tapering 40, 35, 30, slowly tapering the dose. And if it is not functioning, not adequate, the response is not poor, the patient's events is progressing, your inflammatory markers are rising, everything, and histological response are not being attained over a period of time. So the point is we need to consider the patient with your monoclonal antibodies support. Your anti-TNF can be considered, infliximab you can use, and also adalimumab. If you're going to think about that, you can start by very safe molecule. You can consider when you're going to use, start by 160 milligrams followed by 80 milligrams of dose we can maintain, and slowly we can taper the dosage of around 40 milligrams when you're going to do for years together. You can use for 1 year, 2 year, depends upon your clinical response, depends upon your uh, depends upon your histological response, your endoscopic parameter, nutrition status. All these pointers to be assessed when you're going to use a monoclonal antibody support. And this is how you need to slowly titrate the molecule. Now vedolizumab has been well tried, but the cost and other issues to be addressed. But even then, the market rate of this adalimumab is almost going around 20 to 25,000 per dose. But there are so many things, even for the government funding nature still being happening for IBD. IBD society has been well established. So you need to try this process when you're going to manage a patient with IBD. And there are various immune modifiers based upon your response. You need to go for azathioprine once the patient is going to taper with steroids. So you can add the patient with azathioprine support. Always it's to be considered, but look for evidence of any neutropenia, blood counts, and other things to be monitored when you're going to use azathioprine. Not responding, go for your calcineurin or methotrexate. These are all add-on, but there are still need more papers to validate, not much of beneficial role. But azathioprine in steroid, when you're going to taper, at that point of juncture, we can maintain at the rate of around 50 milligrams. Azathioprine dosage can be titrated when you're going to manage a patient with IBD. So titration of dose, tapering of the regimen, add on with your aminosalicylates, when the patient deserves monoclonal antibody, if the patient is having extensive disease, if the patient is having fistulizing disease, if the patient is having evidence of abscess, treat the abscess first and followed by start the patient with monoclonal antibody. All these things, antibiotic support, all those, if the patient is having complex fistula, start with infliximab as a support at that point of juncture. So there are so many things to be addressed when you're going to manage a patient with inflammatory bowel disease. Antibiotics, you can use a metronidazole or ciprofloxacin, but not much of beneficial role in that. One liver patient is going to develop abscess and other complication. You can consider probiotic, no much of paper to document, even then his gut dysbiosis is being well established. So you can use your lactobacillus rhamnosus, your rituri, and other combinations being tried, but still we need more papers to validate the beneficial role of your probiotic. Various experimental molecules like anti-adenosine, anti-integrins, and your cytokines, your T cell depletion, for even your fecal microbiota transplant. All those points are still being there to consider when you're going to use a management of IBD. But symptomatic support, antidiarrheals for Imodium, other things, there's not much of recommendation. Only if mild colitis, at that point, if 1 or 2 doses, okay, but not much. Cholestyramine, if ileal resection in the past, okay. Analgesics, except for acetaminophen, not much of recommendation. That too, for a minimal dosage regimen. And B12, calcium, vitamin D, nutrition, folic acid supplementation when the patient is subject to methotrexate or when the patient is subject to mesalazine. So folic acid is always a must. And iron to be addressed in a prompt way because possibility of septic focus, Yersinia septicemia is high. So you need to be very conscious when you're going to use iron. If at all it's recommended, you can go for IV iron formulation. Surgery, nothing works out, medications fail, patient not responding, rapid worsening of symptoms. So you can go for surgery. So draining of abscess, your segmental resection, your structuroplasty, your ileorectal, ileocolonic anastomosis. So usually, rarely will be curative in Crohn's, but you should see once a patient is going to diagnose fistula. I've seen many experiences with the surgeons who have been frequently, immediately after diagnosing a fissure, they'll be going for surgery. That's not recommended because it will be catastrophe. If the patient is being diagnosed with a complex fistulizing lesion, if you're going to apply a surgical procedure there in the background, there is high possibility for the event to get recur, and the patient may have a further catastrophe of event. So you should be very, very cautious. You need to get to gastroenterologist's opinion promptly before considering the patient whether surgical intervention is there or not. And surgery, you'll see, you can consider ileostomy, your total proctocolectomy, or you can go for IPA, ileal pouch anal anastomosis. Briefly, can be considered. Steroids, as I discussed, the tapering regimen is very important. Slowly, sustained taper, look for response, resistance, and refractory status. Azathioprine, no major risk. And perioperative patients, you can consider infliximab or adalimumab in case if the patient is having suspect increased risk of emergency colectomy. And this kind of patients, we can consider no much of increased risk is there for Crohn's, but post-operative maintenance, you can consider the patient with your ASA or your azathioprine at that point of time. This is the overview status about the various molecules, what we are going to try. Once a patient is going for severe colitis, the ideal molecule will be your intravenous steroids, along with the patient not responding, go for monoclonal antibodies and treat the clinical status, treat septic focus, correct the anemia and other pointers, look for the patient's clinical response. Once the patient is going for refractory, you need to go for your monoclonal antibody support. Quiescent colitis, same thing, fistulizing lesions. You can go for infliximab, that's one molecule which is going to have well respond as per your SHARP and other trial, but you're going to consider. But this is how we need to take care of your IBD. So IBD is very complex area to easy to diagnose, complex to manage, and complex to follow up. And counseling the patient matters a lot. How are you going to tackle important and serial follow-up of complications? Once a patient is going to land up with catastrophic events, early surgical reference, all these pointers is very important. And assessing the extra GA presentation, look for growth, look for nutrition, counsel the patient on nutritional care, and take care as a whole rheumatological approach, your extra GA presentations, and your visual screening. All these pointers is important before you're going to manage a patient with IBD. So H4 analysis, detailed workup is most important to tackle this IBD successfully. Where there's, I'm happy to rest my presentation, which was happened very briefly. And if there is any questions, then I'm happy to check on with you. Thanking you all for patient listening.
Yes. So
Thank you so
thank
much,
you
sir.
so very much. It was indeed a very insightful session, and I'm confident that our audience learned something from your experience. So while you were delivering the session, we had some questions on the back end which I was collecting from the audience. So I would just put forth that one by one. Uh, so first one being about diagnosis. You mentioned about fecal calprotectin. So can fecal calprotectin alone be say a diagnostic measure?
Never,
Or
never, never.
okay,
See, sir, inflammatory bowel disease to diagnose no one single pointers. Fecal calprotectin alone cannot be taken as a significant pointer to diagnose IBD based upon your clinical presentation, endoscopy picture, imaging modalities, your add-on marker, your other active acute phase reactants. All these things to be taken into account when you're going to tackle a patient with IBD.
okay, okay. So even for people who are say on the therapy and just to understand how severe or how how the patient is basically doing, can fecal calprotectin be a monitoring
Definitely,
diagnostic?
fecal calprotectin alone cannot be taken as a consideration to diagnosis. But once a patient starts responding, you can take fecal calprotectin significantly as to monitor whether the patient is responding or not based upon your titration. But fecal calprotectin again cannot be considered alone for monitoring the dosage regimens and all those things, whether the patient response is adequate or not. All these things to be not to be considered as a single marker. You can take a response as an add-on marker with other things.
So second, you did mention about the usage of adalimumab and infliximab when it comes to IBD. So in what cases, are MABs currently used considering the cost aspect? Is it in moderate to severe or only at severe cases?
See, the most important thing, once a patient is going for moderate to severity, based upon all these pointers, you can consider your monoclonal antibodies. But the problem is, even your monoclonal antibodies, your JAK status, JAK inhibitors has been well available now. Your tofacitinib has been well available in the market now. But why I would like to point out your JNS kinase, there are so many other molecules are there. We can consider that. But this thing, you need to rule out the infections. You need to rule out hepatitis B. You need to rule out hepatitis C. You need to rule out your HIV. You need to your tuberculosis. You need to rule out your CMV. Various infections you're not supposed to forget when you're going to manage a patient with your monoclonal antibodies. So you need to tackle all those things. That's why, given best of the gastroenterologist, will be having always a tough status to manage because we need to get ID opinion, we need to get all this thing, we need to monitor the patient yet to food, whether there is any evidence of coexisting infections. All this point is to be answered when you're going to use a monoclonal antibody. The cost issues, 20 to 25,000 is one dose of regimen if you're going to use adalimumab. So first to start with 4 doses, it's coming in 40 milligrams of strength. So if you're going to start with 4 doses, it's almost a 1 lakh cost. So all these things to be addressed, we need to counsel the patient. And next to that, any stricturizing, any penetrating, any fistulizing, extensive abscess, treat abscess followed by your monoclonal antibodies. If the patient not responding to steroid, if the patient severe growth retardation, engage or presentation, worsening of events, a fistulizing another complex scenario, extensive Crohn's, acute colitis, first start with steroids, if the patient slowly responding at the point of junction, you can switch over to your monoclonal antibodies. There are so much of indicators is there for considering your monoclonal antibodies. That's a separate area for discussion. My intention to
Right.
brush up the knowledge today.
Definitely, definitely. So, definitely. So, assuming that mesalamine currently is the first line therapy, so with the available dosages there in the market, if I have to mention about oral dosages, when you're prescribing, say, a mesalamine tablet or a mesalamine sachet, how important is the patient profiling or the clinical manifestations, like you mentioned during your sessions as well, when differentiating between a mesalamine tablet and sachet?
As I already told you, based upon your clinical colitis, whether it is mild, moderate, or severe, you need to start the patient on first line of molecules, muscleizing to be safe. Start very safely based upon your age criteria. You can start by 2 grams, 2.4 grams per day, or you can go up to 4.8 grams per day of maximum dosage, and based upon your clinical response. But only muscleizing, not much of indications, along with steroids, along with monoclonal antibodies, all those things you can use muscleizing as an add-on molecule. We are going to use mesylazine always to consider folic acid. But what is the various formulations? There's a controlled preparation, ileal preparation, extensive pH dependent, various molecules are as well known. Based upon that, your mesalamine when you're going to use, to which area you're going to target, how far is the severity, whether the patient deserves which kind of preparation, whether the patient deserves oral, or whether the patient deserves enema, or whether the patient deserves suppository. All these things will be analyzed. So based upon your lesion of your body, if it is extensive or left side of colitis, or it's only prostacolitis, or it is only pancolitis, if you want to target any indication, all these things you need to address based upon the pH dependent nature. You need to target the molecules with your muscle. Some noise is happening here and there.
No, so I am able to hear you clearly, sir. That answer, was very informative. So, lastly, at the end, you did mention that it is important for us to counsel the patients who are suffering from IBD. So, how important, sir, do you feel is patient education during the entire therapy course, and does it help in preventing relapses among patients?
Definitely. Definitely is very, very helpful. Any patient who is having early presentation. Recently, I've encountered a child who had presentation of oral ulcer for the past 2 years. 14-year-old boy, he had only oral ulcer without any GI symptoms. For the past 14, 2 years, he had recurrent but been treated by a physician with simple medication for the patient didn't respond. Again, minimal response, again the patient started to have oral ulcer. Minimal response started oral ulcer. They didn't work up in terms of any IBD. They didn't work up the patient in terms of any Bechdels. So that's the main problem. So we need to work up this kind of patients properly. That's eye area to miss out. Once a patient is going to come into the so still not being the tip of iceberg only we are seeing. Apart from that, most of the cases are still submerged. We couldn't able to diagnose that. That's one thing we need to address very promptly. Apart from that, the next issue is how are you going to see, even if you're going to diagnose, how are you going to counsel? Because Even if you manage, we are not very sure whether the patient respond or not. Lifelong medications, lifelong follow, most of the time, prevention, progression, assess for malignant changeovers, all these things is very important because most of the patients, that in India, this see the privileged status is still not able to well established. That's why we need to titrate based upon the clinical response, minimal molecule, maximum target. That's a motive for us to treat the IBD. The IBD foundation has to be strongly established if you want to tackle this scenario well.
So thank you so much, sir. Just last question. These were our questions from the audience. There's just one question from my end, if I may ask. With regards to education itself, going beyond the pill, there is a patient education initiative that we are doing as well. So two aspects to it. One is in the form of health camps, and other one is, if at all there is an interface on like a mobile application. Do you think such kind of intervention would help patients, like you mentioned about prevention, progress, and monitoring? So do you think both these things, health camps and mobile interventions, can help patients?
Definitely, health education matters a lot, sir. Because health education, early presentation, early recognition will prevent most of the drastic, dramatic, worsening complications to develop. So always the health education in whatever the medias which is being available, early screening, early intervention, refer the patient promptly to the IS center and to be intervened promptly by the gastroenterologist. That's the most important thing to overcome all the complications successfully.
So thank you so very much for such an insightful session. Again, sir, my name is Harsh. I am from the marketing team of Dr. Reddy's. It
Yep.
was a pleasure meeting you, and thank you for your valuable time.
Thank you very much. Thank you, Team Ready to Organize, and thank you for all the delegates who are being here. Thank you all once again. Thank you very much.